challenges. Today's session is here to provide hope, understanding, and clarity. We are honored to be joined by Dr. Eli Reshef, reproductive endocrinologist at Advanced Fertility Center of Chicago. With decades of experience, Dr. Reshef brings both scientific insights and deep compassion to this conversation today. He will guide us through causes, diagnostics, pathways, and a range of treatment options available for our patients. Following the presentation, we will open a session for Q&A. We'll approximately dedicate 30 to 20 minutes to this session, so please feel free to jot your questions in the chat box and we'll answer as many questions as possible. And without any further ado, please join me to welcome Dr. Reshef.
Evening, everybody. I'm calling you from Chicago. It's a beautiful evening, and I'd like to start with a true story, and the true story involves me. About 20 years ago, I decided to join the corporate challenge, which is track and field competition between corporations. And since I was a pretty good athlete in high school, I said I'm going to enter several events, including the 100-yard dash. Looked around at my competitors, and I said, I got it. And I came in second to last. And I ached for about 3 months after that. So it was a lesson in humility. And the reason I'm telling you this is this. I was working under the assumption that I'm just as good as I used to be. And of course, painfully, I was not. And that's one of the issues with secondary infertility. You've been pregnant before, you have a child, and now you have difficulty getting pregnant. You're operating under the assumption that everything is the way it used to be. However, what we have to figure out here, especially in regards to the female partner, is the fact that the ovaries are not waiting. The number of eggs and their quality decline over time. There could be other events. So we'll talk about secondary infertility. I think it's a very important topic and very, very common among my patients. Next slide. So let's talk about why does it happen and what we can do about it. Next slide. A definition is secondary infertility refers to the inability to conceive or carry a pregnancy to term after previously having one or more successful pregnancies. By the way, that does not include IVF pregnancies. So, but it's common. It affects about 10% of couples who have had a child before. And once again, they wonder why it was relatively easy for those that it was to get pregnant and have a child, and now it's so difficult. So once again, the assumptions usually that the couple has, or especially the female partner, is that my fertility is the same as it used to be, and they may not be correct. And that's what one of the goals of the testing is, to look at egg reserve. We'll get back to it again, but there may be other factors, including male factor, that may deteriorate over time. Clearly, the emotional impact is huge because, again, you were buoyed by your success in the past, and now it's very humbling to have significant difficulty. There's social pressure. People make the assumptions around you that you're fertile and you can get pregnant again. And what do you know? It doesn't happen. Next slide. So what could be, in terms of female factors, what could be wrong? I think you need to look primarily at the upper left side of this complicated process. Because really, especially if you're over 35 and you've had a child before, your egg supply, once again, I'll harp on it over and over because it's so incredibly important. Your egg supply diminishes over time, and there's nothing you can do about it, unfortunately. You can make it worse by being a smoker, meaning nicotine, but most other factors in life, such as diet, exercise, air quality, or other factors like that, do not impact your egg supply. You have been born with about half of the eggs that you started with when at the peak of your ovarian reserve, which was halfway through your mother's pregnancy with you, and the egg supply between 20 weeks of pregnancy and full term, and then Beyond that, diminishes over time. That kind of march goes on and on and on, whether you are on birth control pills. It does it before you reach puberty. It does it after that. It does it even when you're pregnant. There are waves of eggs that are trying to make it. Only one makes it, at best case scenario, uh, during an ovulatory cycle. Remember this, you have about 600 eggs that will ovulate over your reproductive life. 600. So we start with 4 million when we're halfway in our mother's womb. I say I'm talking about females. You are born with about 2 million. When you started puberty, you're about 300,000 eggs. It's a rapid decline. And over your career, reproductive career until menopause, you will have probably about 600 eggs that will be ovulatory. It sounds like a very sad story, but that's the fact of life. So, ovulatory dysfunction or abnormalities of ovulation are part of the problem with secondary infertility. For those of you that have regular periods, you most likely ovulate normally. We can assess that. But clearly, if you have positive on your ovulation predictor kit, you probably ovulate an egg each month. However, you don't know if the quality of that egg is normal or not. And chances are the older you get, the more abnormal eggs you get. For example, at age 36, you have half of your eggs are normal, half of your eggs are abnormal. At age 40, it's probably about 65, 35, 65 abnormal, 35% normal. Abnormal eggs will not become a baby. They either will not fertilize or else once fertilized may not implant. Once implant, they will miscarry. So there is a pretty accurate filter by nature that does not allow abnormal pregnancies to come to continue to term, except for the uncommon cases, 1 in 100 when you're 40 of Down syndrome. Okay, 1 in 200 when you're 35. So for the most part, abnormal eggs will not fertilize or will miscarry. And so it's harder to get pregnant when you're older. It's harder to keep the pregnancy. There are more miscarriages. And of course, there's some increased risk of abnormal pregnancies, but that's a different topic. Most people, if they ovulated before, will continue to ovulate unless for some reason they gain significant amount of weight or they have significant stress in their lives. If they had open fallopian tubes before, I would say tube, because if you got pregnant, at least one of your tubes are open, but not necessarily both. Tubes can close off if you have infection or if you had any kind of infectious event after delivering your child, such as C-section that had a lot of infection to follow, appendicitis right next to the right tube that may have blocked the right fallopian tube, etc. Endometriosis can progress over time to become more impactful. The older you are, the more likely you are to have greater amount of endometriosis. Uterine abnormalities are usually not as common, but fibroids are, especially if they impact the cavity. Fibroids on the whole are not a cause of infertility, but you have large fibroids inside the uterus, polyps inside the uterus, or even scar tissue, then those clearly can negatively impact implantation. So, but I would direct you to the ovulatory disorders and age-related decline in fertility as one of the causes that we need to investigate. Next slide. When it comes to the male, there might be some age-related change in quality of the sperm, but it's not as constant. There is a well-known decline in the ability to have an erection, maintain an erection. Erectile dysfunction is more common the older you are. Varicocele, which is a dilated vein in the males, may increase the temperature to the sperm production area and therefore decrease sperm production. So it's not that males, when they get older, have worse quality of sperm. It may be true, but remember that a lot of males may be more prone to illness and lifestyle changes, more stress, and other medical conditions that reduce the quality of sperm. Next slide. So Is smoking impactful for sperm and eggs? Yes, it's a negative impact. Alcohol, unless it's really in excess in males and females, does not have as much negative impact on sperm quality unless people drink more than one drink a day on the average, 7 drinks a week. But in a female, it has not been shown to have significant impact. Those of you that smoke marijuana or use marijuana in any other forms, probably doesn't have much impact in a male or female. There is some negative impact on sperm if you're a male and uses marijuana very excessively. Diet and nutrition are important, but it's primarily related to weight gain, both in the male and the female. Weight gain in the male will reduce sperm quality and quantity. Weight gain in the female may interrupt with ovulation and increase the risk of miscarriages. Exercise uh, may usually have positive effect, but people that, those of you that are excessive exercisers, that may interfere with ovulation. So be aware that that excessive exercise, the triathletes, the avid runners, and all that may actually have reduction in their ovulatory function. And stress management is important at any point in life. And so if you have ways to reduce stress, yoga, Pilates, um, uh, transcendental meditation, or any other forms, exercise included, please exercise those. They have positive effect. Next slide. That's a very important point that sometimes, despite thorough testing, we will not find a cause, but then we have ways to treat it. Next slide. So you have to be accustomed to the fact that even with very extensive testing, we will not find the cause of your secondary infertility. Medical history is important. Has anything happened after delivery? Have you had a C-section, for example, with a lot of infection? Was the placenta retained, and therefore they had to go in and do a DNC after you delivered, whether it's vaginal delivery or C-section? Has there been any other infections? What are your periods doing, etc.? So what we do in terms of evaluation after getting a thorough history for secondary infertility is we do some testing. The testing includes hormonal testing, and that's primarily a hormone called AMH, anti-Mullerian hormone, that basically indicates your egg reserve. It doesn't tell you about your egg quality, but it has a kind of refers to the total sum of your eggs. Those of you that have low AMH, that can be an explanation. By the way, we also do ultrasound to look at the ovaries. Ovarian reserve testing is both doing AMH, looking at the ovaries, counting the number of follicles, what we call antral follicular count, and put it together. Those, however, should never serve as a gateway or a threshold. AMH level below X means you'll never get pregnant. Incorrect. Antral follicular count below X will mean that you'll never get pregnant. That's incorrect too. Okay, so make sure that your doctor and yourself do not hang on the lab values and say, abandon all hope. That is completely incorrect. With regards to imaging, we want to make sure your tubes are still open. The cavity of the uterus is still normal. There is nothing that impinges on the cavity like fibroids, or inside the cavity like fibroids and polyps, etc. So the diagnostic testing that you see on the right will be suggested to you. Next slide. And clearly the cornerstone for male evaluation is semen analysis. Okay. So next slide. That's a complicated slide, but we have various ways to deal with that. So there is an app for secondary infertility. One thing is to reassure the person after they've done the appropriate testing that the tubes are open, the sperm is fine, she ovulates, and therefore maybe we can use some low-cost strategies after you get the reassurance. One low cost is, of course, no intervention. Remember, after the imaging or the putting fluid in the uterus and flushing the fallopian tube, there is some increase in the chance of conception, even naturally. So, especially if you're not over a certain age, there's no harm in trying for 3 or 4 more months after the imaging test if everything else checks out fine. We can use fertility pills to increase the number of eggs that you produce, or in the case if you don't ovulate, to make you ovulate. We can do inseminations, what we call intrauterine insemination, IUIs, to put the sperm directly in the uterus. And in a second, I will also tell you about the chance of conception with IUI compared to regular intercourse. And of course, we can go through more expensive and extensive strategies that are actually more effective, but we usually don't offer them right away unless people say, hey, doc, I understand that you want to go gradually, but I'm distressed and I want IVF tomorrow. And I don't think it's bad as long as we explain and as long as the patient has done her due diligence, the couple that is, and are aware what goes into in vitro fertilization, not only the cost, but the needles and the stress and everything else. Clearly, lifestyle changes are important, okay? And I will go as far as saying, for those of you that have BMI over 30, what we consider obese, strategies to lose weight should include the new weight reduction medications, the GLP-1 receptor agonists and others. The strides that we have taken, the medical field in weight reduction, has been incredible in the last several years. Weight reduction surgery, if anybody has ever gone through that, is obviously a very extensive and relatively dangerous process. And while the injectables, the Mounjaros of the world, or Ozempics, etc., are not completely without risks, they have tremendous efficacy in weight loss. In the case of tirzepatide, Mounjaro, 24% reduction in body weight in a year's time. And that by itself can make you ovulate again, reduce the chance of miscarriages, et cetera. If you look at the manufacturer recommendations, they say don't be on those medications for 2 months before you try to get pregnant. That is incorrect. Studies have shown that even if people get pregnant when they have Ozempic on board, what we call Ozempic babies, there is no increase in the risk of birth defects or any other adverse effects on the child. So our policy is if you are on Mounjaro, let's say, Ozempic or otherwise, when you find, or right before you get pregnant, stop it. But until then, you can continue to lose weight, okay? Even during treatment, okay? Once you're pregnant, you stop it. Next slide. One asks about what kind of diet, what kind of vitamins should I take to improve my fertility? Here's the true answer, and I know this is not what you were hoping for. There is very little evidence that taking antioxidants will improve your fertility. It's not going to harm you unless you take mega doses, especially of vitamin A, which I don't recommend. You don't want to expose your pregnancy to excess vitamin A. It can cause birth defects. But vitamin E, vitamin C, CoQ10, there's no harm in using them, both male and female, but the impact they have on egg quality is minimal or sperm quality is minimal. Now, I'm not saying don't use them. I'm just saying don't pin your hopes only on those medications. Clearly, a healthy diet is helpful for any aspect of fertility. But remember that diet, unless you're really a strict vegan and iron deficient and all that, diet will not have as much impact on your fertility, not as much as you think. So various other treatment modes, they need to be negotiated or they need to be explained to you. And in this day and age, you have your fingers on the same resources as I do, any AI search engines, PubMed, which is the National Library of Medicine, where we get our article, etc. And you are empowered to do research and, of course, present it to your own healthcare provider to make sure they're up to date. Next slide. So we can do inseminations, we can do in vitro fertilization. Generally speaking, depending how old you are, inseminations are not as helpful as you think. If you're 35 and fertile, okay, your chance of getting pregnant every month is probably at best 5 to 10% without any intervention. If we do an insemination, it may increase you to 10%, but the impact is not very high. So if it's 10% per month, if you do insemination, IUI, not in vitro, as you see on the picture, it's not going to have a significant improvement of your chance. And if you decide to do IUI for the few percentage points that it may increase your chance per month, don't do it more than 3 to 4 times max. In vitro, very effective, especially if you're over 35, and we can test the embryos to make sure that they're normal. A lot of pregnancy failures, including miscarriages, are because either it's abnormal sperm or commonly abnormal egg that became an embryo, but obviously those are not destined to become a baby. With in vitro fertilization and screening the embryos for chromosomes, what we call pre-implantation genetic testing or PGT, we can identify normal embryos. And you can also find the gender if that's important enough for you. But the current thinking is that that's still debatable, that if you do in vitro fertilization, you screen the embryos and put in a normal embryo, you have more chance of taking home a baby and less chance of miscarriages. Okay, but in vitro, as you well know, is expensive and extensive, etc. There is another option for those of you that have tried, and we tried several other ploys, including in vitro, and your egg supply is really dismal, and that is egg donation. And there is a big jump. Psychological jump to agree to have somebody else's DNA in your life. So egg donation, very effective, but clearly most couples that I meet would like to have a child with their own DNA. Okay, so next slide. I think that the emotional distress must be addressed. You need to be able to talk to somebody, whether it's a partner, whether it's friends, and whether it's a counselor. It's very important. Support groups, like those in Resolve, are very important as well. Remember that as you walk on the street, 1 in 6 women in reproductive age is infertile. Okay, some of them with primary infertility, some of them with secondary. Infertility is very common. It's very painful. You look healthy. Nobody can tell. You don't wear a big eye for infertility on your forehead, but it's the level of stress for infertility patients is just as high as that of cancer patients. So that should be addressed and should not be ignored. Next slide. So I mentioned some stats on IUI. I think the 10 to 20% per cycle is a little optimistic. The 40 to 50% per cycle with IVF is more realistic. So again, you have a menu. That's not to say that you have to pick up the lobster on the menu, which is in vitro fertilization, but there are apps for your secondary infertility. Next slide. So I'll summarize. Secondary infertility, not being able to get pregnant after having had a successful pregnancy. If you're under 35, it's if you try for a year. Over 35, you try for 6 months. An important and common disorder. You should be empowered to talk to your reproductive endocrinologist because there are solutions. But first, let's do evaluations. So let's move to questions and answers.
Wonderful. Thank you, Dr. Ashef. It was very insightful, and we have a few questions already. The first question, can you explain why an abnormal egg would implant successfully in the first place?
I missed something. Why a normal? Why an abnormal egg?
Why an abnormal egg would implant successfully?
Well, I don't know what you suggest as success. What I mentioned before is that success may mean for some people it implanted, but success really, how we define it is by a live birth or a baby in your arms. That's success, not a miscarriage, okay? Abnormal eggs, as I mentioned before, may not fertilize. When they do fertilize, they may not implant. If they do implant, which is a small proportion, they will not progress to become a baby. And most miscarriages, meaning that you lose that pregnancy, typically abnormal, will occur by the time you're 8 weeks pregnant. So not very often would an abnormal egg become a baby. There are some, exceptions. Everybody knows about Down syndrome or Turner syndrome. Very few chromosomal abnormalities will become a baby. Okay, the majority of them, vast, vast, vast majority are filtered out by nature and will not become a baby.
Thank you. Our next question. Are there any questions you would advise asking your reproductive specialist if you have a low AMH at age 40 and trying IVF for the first time after having a healthy child naturally at the age of 38, trying to best educate myself, but there is not a lot of information out there?
Okay. Well, if you have low AMH, you are at a disadvantage. Well, once again, let me reemphasize the fact that you should not be discouraged by low AMH. You should be cautiously optimistic. The AMH really helps us, the reproductive specialists, create a protocol for stimulation for in vitro fertilization, stimulating for you to produce as many eggs as possible. There is no AMH under which you say abandon all hope. Okay, as long as you still have periods, etc. If you're menopausal, you're unlikely to get pregnant, regardless of IVF and things like that. So a lot of time I have people with very, very, very low AMH, and I say to them, if you try IVF, if you try regular intercourse, or if you try insemination with fertility pills, you'll have the same low success rate. Why pay for IVF? But that's really not very common cases. If people still have some evidence that the ovaries are functioning, the AMH is greater than 0.1, then they're worth trying IVF. And we try to tailor protocols to produce as many eggs as possible. But remember this, if you're 40 and we do IVF when you have low AMH and probably also low number of intrafollicles or eggs, it's not just getting eggs out of you, but the fact that many of those will be abnormal. As I mentioned, 65% of eggs at age 40 are not normal, and 35% are. So you got an egg, you can't look at an egg or test it to see if it's normal or abnormal. It has to be fertilized. So the product of fertilization, meaning an embryo, can be tested. But if you have very few eggs, very few embryos, fewer embryos, then those embryos may not even grow to allow a biopsy. You may end up with 0 embryos for that cycle. The question is, do you do a fresh cycle? You wait, and if you end up after 5 days with no embryos, it's meant to be. Those are things you need to discuss with your physician. But for those of you who are 40 and have low AMH, in vitro still can serve as a solution, but be cautiously optimistic and be prepared for a fairly tumultuous journey.
Thank you. The next question is, if all our tests are normal, how would you treat unexplained secondary infertility? Isn't that just a guessing?
In our field, the recommendation for unexplained infertility, whether it's secondary or primary, is to do maybe up to 3 cycles of fertility pills and inseminations, IUIs, and then move to IVF. And I apologize for suggesting IVF so quickly, but again, if you look at the effectiveness, and you just saw the slide that showed you the difference between IUI and IVF in terms of success rate, you'll understand why we try to provide you with what works best. Whether you choose it or not, that's your own business.
And there is a follow-up question actually related to that. Are IVF or IUI success rates higher for couples with secondary infertility compared to those who's never conceived before?
I think generally, yes. Okay. as I explained to a couple that came in today to see me, this is real. And I say, they've had two miscarriages and two live children, been trying for 9 months now. She's over 35. And I said, um, clearly we can do IVF and all that, but let's do the preliminary testing, and you are welcome to try on your own because you have already shown that you are able to get pregnant. The problem with that particular person that her egg supply is now diminished. We have an AMH and an ultrasound that show indeed, just like when I ran the 100-yard dash 20 years ago, that you don't have the same mojo, or your ovaries don't, as you used to have. So you have to take that into account.
Thank you. The next question is, how long should we try naturally before seeing an infertility specialist? We already had one pregnancy. Is
Okay.
it age related?
Definitely age related. If you're under 35, if you tried for a year, you should see a fertility specialist by whether it's primary or secondary infertility. If you're over 35, 6 months. However, let me mention that to you. If there are clear reasons why you are infertile, for example, you have no periods, there has been a vasectomy and reversal, something like that, then see the physician as soon as you can.
Okay. Our next question is about hormones. Is it possible that hormonal changes after breastfeeding or stopping birth control are interfering with my fertility now?
It's general knowledge that within 3 months after you stop breastfeeding, your hormones will go back to normal. And likewise with oral contraceptives. Typically, 3 months after stopping oral contraceptives, you should start ovulating on your own. Sometimes there's a rare situation after birth control pills. It's called post-pill amenorrhea, where you don't have periods for up to 6 months or 9 months, in which case you need to be evaluated. For the most part, if you think 3 months after breastfeeding or 3 months after stopping birth control pills, you should be back to baseline.
Okay. Dr. Rashif, you talked about weight medication, Mounjaro, Ozempic, and others. There's an interesting question. We both had COVID last year and we are vaccinated. Could that have any long-term effects on our fertility?
The general consensus in my field, and there are many studies that show that, no, COVID does not cause infertility. COVID vaccine does not cause infertility. So there have been some suggestions, some menstrual changes that are temporary after COVID or after COVID vaccine, but they're really fleeting and do not have a significant impact. In fact, again, remember the following. You may, again, look at the literature. COVID or COVID vaccine do not cause infertility, secondary or primary.
Right. Thank you. Our next question, I'm not sure how you'll answer this, but I'll read it for you. Our child has started asking why they don't have brother or sister. And there are resources is there any resources to explain to them in a sensitive way why parents cannot conceive?
That's a great question. And, in disclosure, I have family members who have gone through the fertility journey, and whether it's secondary or primary, and I wish there was a stock answer to that. Some couples will find it in their heart and mind to explain to the child, perhaps not that specifically about the fact that perhaps they are the miracle and we're hoping for another miracle. And I don't think it's twisting the truth.
Mhm.
If you hit a ball, a golf ball, and you have a hole in one, it's a miracle. Well, you can call it miracle, you can call it a low probability event, but in some cases, including secondary infertility, it's a likelihood of hitting another hole in one, especially if you had a very long journey to get pregnant to begin with. Okay. And once again, there is a way, I think, to I wouldn't call it divert, but I think it's to create within the child, the impression that they are the miracle, and we're working on another miracle. And we're hoping, some of us are praying for another miracle. I don't think it's a wrong way to frame it for a child. And sometimes, depending on the age of the child or depending on how comfortable you are communicating with your child, you can talk about the fact that sometimes it's difficult, and you can create examples. You want to go to baseball? What's the likelihood that even the best hitter in the league hits a home run every time they're at the plate? Not very high, right? Everybody strikes out. And so if people want to use that example for kids that understand baseball, I think it makes the point. Or anything similar to that. What's the likelihood of scoring a goal? You know, so I trust that many of you will have the wherewithal, intelligence, and articulation power to be able to explain to a child.
Staying on this topic, I have a question. Speaking about couples who already have a child, some clinics do not advise to bring the children under age of 12 to the clinics if they're patients of IVF clinics. What is the reason for this kind of advice?
Um, Man, I didn't make those rules, but back when I was practicing elsewhere, our waiting room, because I practiced as a reproductive endocrinologist, I didn't deliver babies, but I practiced. We had a large waiting room that had pregnant women there too, which is a very, very painful um, event for people who have been struggling. Okay. Now, obviously, that's not the same thing. Maybe they talk about distraction and all that. So, um, I wish I had an answer to that. I think primarily distraction for other patients, but I wish nobody's ever asked me that. Good question.
Thank you. All right. We just received another question. Could autoimmune conditions like Hashimoto or lupus contribute to secondary infertility, even if they didn't affect my first pregnancy?
Yes. So thyroid conditions are very common in the general population, more in women than men, and they are more frequent the older you get. Hashimoto's is basically autoimmune thyroiditis, essentially where your immune system turns against your thyroid. And typically with Hashimoto's, your thyroid becomes overactive because it's leaking thyroid hormone, which is related to, believe it or not, to amphetamine. And then it burns out. So now you're low thyroid. Significant hypothyroidism, more common than hyper. Overactive is much less common than underactive. May impact menstrual function, ovulation, and otherwise, but it has to be fairly significant. We talk about subclinical hypothyroidism, and some of you, good number of you, probably are on levothyroxine for having subclinical hypothyroidism, where your TSH is elevated, but your thyroid hormone is not. So your doctor wants to give you a little bit because your brain is seeing what your thyroid is not making and strains it. That's why your TSH is high. So giving thyroid suppresses the brain and may improve your symptoms. Unless it's significant hypothyroidism or hyperthyroidism, this is not a common cause of infertility, but it needs to be evaluated because it's so common.
And those tests, are they normal tests in your practice, or should I, as a patient, go test TSH level myself prior to coming to see you as a practitioner?
Oftentimes, your primary care physician will do it, but we almost automatically do it on new patients because of how common, especially low thyroid is, and how easy it is to address.
hmm And so let's talk about this a little bit more. Once, issue is determined, for instance, with the TSH level, what will happen next? And what is the time frame when we're looking at, starting maybe IVF cycle?
Well, if you're a TSH, we now are looking at TSH of 4.0 and above is abnormal. We used to think of 2.5. Some of your physicians may be still under the impression that 2.5 is the threshold. No, it's 4.0. So if your TSH is less than 4.0, you don't need thyroid replacement, or if you're already on thyroid medication, no need to change. If it's over that, remember, it takes a month or two for the thyroid to stabilize. So after initiating thyroid treatment, levothyroxine, we don't recheck the thyroid any earlier than 4 to 6 weeks after the dose change or initiation of therapy. It probably will not impact your uh, ovarian response, so you can still do retrieval, but I would suggest that you do your embryo transfer later once your thyroid is stable.
Okay, excellent. Thank you. Our next question is, I had complications during my last delivery. Kind of touch base on those complications previously in our slides, including retained placenta and hemorrhage. Could this affect my current fertility levels?
The answer is most likely yes, but not always. Okay, so it goes like this. The more severe case of scarring after retained placenta and doing a later DNC, whether it's after C-section or vaginal delivery, can stop your periods. This is a condition called Asherman syndrome, where the scarring that is produced by that particular event, a pregnancy event, and instrumentation, may cause your cavity to have scar tissue and for you to stop menstruating because there's so much scar tissue there. That's a more severe case. The less severe case, and especially if you may have noticed that there's some change in your menstrual character, meaning less days and less flow, then that's also alarming that you may have some scar tissue, perhaps not as severe as the Asherman syndrome, but pretty impactful in terms of implantation. Some people have still regular periods, but any of you that have had complications, including infection, retained placenta, DNC after retained placenta, and all that, need to have some imaging done, primarily either hysteroscopy, where we look with a telescope into the cavities to see if there's any scar tissue, and if found, it needs to be treated. But clearly, that's one of those warning signs that something may be negative in the cavity and receptivity for an embryo.
All right, thank you. And I see the last question that came to the chat. Is there an ideal age gap between kids that's easier for conception from biological standpoint?
Well, I can turn this question around a little bit and say, is there any age where you say, stop, don't try anymore? No. Obviously, the less likely you are to get pregnant, the older you are, the less likely you are to get pregnant, but you are still able to conceive even in your mid-40s. It's less common. You need to be more accustomed to failure for miscarriages and all that. So, generally speaking, the younger you are, the better prognosis you have. But it also relates to egg supply. Okay, and a few other factors. I mean, you can be 25 years old, having had a child at age 22, and your egg supply will be so diminished, genetically, of course, has nothing to do with your behavior or exposure, and that could be the major reason why you're trying to get pregnant unsuccessfully. So that's why we need to, even as young as 25 or any age, basically, if you have secondary infertility, we need to check your ovarian reserve, egg supply, to make sure and it's more common than you think, especially in our patient population, because we see the people who have not been able to get pregnant, who maybe were evaluated or treated briefly by their OBGYN, and they come to us because they were unsuccessful. So evaluation of egg supply, once again, is a summary. Evaluation of the fallopian tubes and the cavity of the uterus, making sure you ovulate, and making sure that the male still has reasonable sperm analysis are the cornerstones of the routine evaluation for primary and also secondary infertility.
Thank you. And I said too early that it was the last question. We just received another one. I apologize. What is the best way to prepare your body for an embryo transfer after IVF? Do you recommend more than one embryo for transfer for a success rate?
Well, great question. We can do an embryo transfer depending on how you do it, immediately when you have a period after your retrieval. And whether we use estrogen and progesterone to prime the lining, it's fine. It can be done. The question is, are you ready mentally? And of course, you'll answer that. Uh, there are obviously people that use, or sometimes we use the natural cycle, or what we call natural cycle frozen embryo transfer, in which case, if your ovaries are not back to baseline after the retrieval, sometimes it takes them a month or so for the follicles and the cysts to diminish and for the estrogen to be baseline, then you might need to wait a month or so. But there is no set time. You can do it ASAP. You can also, if you have frozen embryos, if they did a freeze all or things like that, and they have the retrieval, now we have embryos in the freezer, you can say, I want my embryo transfer to be done in X amount of months because I don't want to deliver it another X amount of months. So you can actually direct it in such a way that you'll deliver at the time that you wish to deliver.
And Dr. Reshef, the second part of that question was about transferring more than one embryo at a
Ah,
time. What's
yes.
your standpoint on that?
Okay. Very important question. Desperation may lead to decisions or desires that may have unintended consequences. Because a lot of people that come to me, whether it's primary or secondary infertility, they say, put as many embryos as you can in me, or I want my twins after I had one or two. And I would say to that, we generally say no, unless there are special circumstances, because the consequences of prematurity, which are generally occur in almost every case of twins, can be devastating. So then you look at the child or children that are impaired for life because they were born at 24 weeks, the kind of sort of edge of viability, and you say, I should have known, I should have had a V8. If that, and a lot of time our desires will cloud our judgment, and the doctors will have to say, and I do it almost every day, no two, just one. Unless you failed numerous times with one, or unless you're older than 35 with untested embryos. And one of the great things about the Society of Assisted Reproductive Technology, which is the voluntary body that oversees most IVF cycles in the United States, is they created guidelines. And I shouldn't say they, because I'm on the board of that organization. It's we. And that is one of the reasons why we limit the number of embryos transferred. And that's the main reason in the last 15 years, there have been a significant reduction in twinning. So a lot of people, unless they are familiar with prematurity, will consider twins a blessing rather than a curse. But remember, 1 + 1 is not 2. 1 + 1 is 3 or 4 or 5 when you talk about complications and cost and things like that. Think of having your twins in IVF 2 years apart. Frozen embryos, have one transferred, deliver your child. Whenever you're ready for another one, you'll deliver the twin by another frozen embryo transfer.
And please correct me if I'm wrong. There's still opportunities to have a twin baby, even with one embryo transfer.
Well, I am the proud grandfather of twins that were created from one embryo that split. So it figures out that child of a reproductive endocrinologist will have in vitro and have identical twins, but it doesn't happen very often. Usually one embryo, one baby.
So if hypothetical, if you're transferring two embryos, you might end up with four.
Well, it doesn't happen very often, but it's a possibility, but a very, very low probability.
Okay.
But think of one healthy baby. It's very important to think about that rather than thinking of completing your family by doing a twofer, but then regretting it because of premature delivery.
Thank you. I don't see any more questions in the chat box at the moment. I'll wait for a couple of seconds and give opportunity for everyone who's on the call to make this last minute decision and ask Dr. Reshef. But Dr. Reshef, thank you so much for your time today. It was unbelievable discussion and very insightful. I learned a lot myself today, so I really appreciate your time. For our patients, if you would like to make your appointment, any clinic within the network, we have 90 clinics within the network. Please feel free to scan the QR code. We do those webinars once a month, and Dr. Reshef will be with us as well in a couple of months, leading another subject. So please check the calendar, and we invite you to join. You will receive a copy of this webinar as well, so you can watch with your partner at any convenient time, or if you register for a webinar and unable to attend next time, you also will be able to watch the recording. Thank you once again for joining, and I wish you a pleasant evening. We'll see you later. Goodbye.